The Modern Pain Podcast is a proud member of the PT Podcast Network. Make sure you check out ptpodcastnetwork.com for other awesome PT-related podcasts. Welcome back to another episode of the Modern Pain Podcast. This week we have a conversation with Ben Whybrow, a physiotherapist specializing in pain management at an NHS pain clinic. Ben's going to discuss the multidisciplinary approach to treating complex pain cases where they emphasize the importance of patient communication and empathy. He shares his thoughts on managing difficult conversation around ingrained beliefs, the effectiveness of group dynamics in treatment, and strategies for addressing emotional challenges we see daily in the clinic. This is something you cannot learn in the classroom, and you have to learn it sitting in front of another person and having these difficult conversations. Thankfully, this episode is going to help you better navigate these conversations in the future. Enjoy the episode.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Ben.
Well, thank you for having me, Mark. It's a pleasure to be here.
This is another one of those like digital friendships from X, Twitter, whatever the heck we're calling it now, where, I always, as I'm having discussions on there, it's a good sounding board of ideas and thoughts and seeing what people are doing out there. And a lot of great researchers, obviously. I always say it's like, free continuing education because you're able to, see what's getting published, see a lot of discussions around it, things that normally you have to wait to a conference to get in front of those folks if you're able to attend those. But Ben, you've been involved in some great discussions and I've obviously enjoyed your perspective. We wouldn't have you on the podcast. No, I try to keep all perspectives in mind and try to engage with even ones I may not agree with, but yours, of course, I do. Before we get into talking about what we'll talk about today and some of the stuff around difficult conversations, I'd love if you could kind of introduce yourself for the audience and kind of let them know where you're at and what you're up to.
Thank you. My name is Ben Whybrow. I am a physio over in the UK. I work in a pain clinic for a wonderful NHS. I've been doing that now for 4.5 years, and I'll be next year 10 years in the profession. On top of that, my other smaller job is I work for now the University of East Anglia. We do something called clinical communication skills, which is something they do in the medical schools around the country. And it's essentially facilitating or teaching the medical students how to talk to patients about various things. And it starts fairly simple with things like taking a history, building rapport, and then as their years go on, it gets to all the interesting things like sexual history, reproductive history taking, death and dying stuff, palliative care, breaking bad news. There's even a pediatrics one in the 4th year where they're getting kids from a local school. So I do that a small amount, but my main job is with NHS Pain Clinic, which has been 4.5 years now, and most of my career in the kind of musculoskeletal field.
Now, NHS pain clinics, what does that look like as far as what kind of setting is that and what kind of, obviously we're working with patients who are dealing with often some complex pain issues, but I'd love if you can unpack a little bit of like what a day looks like in the clinic there. And I know sometimes there's some challenges. We spoke to Pete Moore last week and he had mentioned for some of the pain programs, I don't know if that's currently with your pain programs, there can be a decent wait to get in. I'm curious what that environment's like over there.
So I can only obviously speak for mine. Pain clinics or even pain services, if we call it that, are going to look different geographically across the country. But generally, you'll have it's an MDT approach. So physios, we have psychologists. Our service has occupational therapists. And then we have nurses and consultants as well. We are seeing the people where they have been through the mill of conservative management or surgical management as well. They have had all of their standard investigations that they shouldn't be expecting any more scans, blood tests, anything like that. The diagnosis theory should be done. And our patients can come from anywhere. So yes, there is a ton of back and leg pain, neck and arm pain, or widespread fibromyalgia, CRPS, things like that. But we also get, like, for example, post-surgical pain after cancer surgery, hepatic neuralgias. In theory, it can be pain anywhere. That includes pelvic pains as well. And we will essentially work as the team to support the person. The person, depending on their needs, may not have any physio input at all. they may have a lot of physio input and not much psychological input. Obviously, we're trying to treat them as people, not as pathologies. And we do, like Pete Moore had, we do have pain management programs. So the pain management program, do you have them in the States at all, Mark?
Not as many as we should have. We used to have multidisciplinary pain programs, but then per usual in the US, the financial components of it, it's hard to deliver and, keep it a financially viable thing in our more invasively profited system that we currently reside in here in the US, but not a ton.
Okay. So we have a pain management program is a combination of the physio, psychology, OT, and a few other bits. Now the timescale is variable on different services. So ours, for example, it is 3 weeks, 4 days per week, and people either do it virtually over Zoom or they come in person. I know there are other services that do theirs once a week for 12 weeks or twice a week for 8 weeks. It depends on the service and the needs of the people. But it's the combination of the entire team. And I'm going to be honest with you, the patients on it take more from each other than they take from us, which is what they want, ideally, because they're meeting people like themselves who they probably haven't met in society before. You and I see people with persistent pain every day, right? We're used to it. People in society or patients we see, they often might not meet many people like themselves. And that combination of when we start them on the first day and we say, how does your pain affect you? And someone says, I struggle to sleep, struggle to do my shoes, I was working, boom and bust. It affects all aspects of my life, from financial to intimacy to all sorts of things. And you see them next to each other nodding along going, yeah, it affects me too. It's that group dynamic that almost brings them together. Like anything, there is a weight. The weights depend on where you are in the world. But I would say we will always assess our patients first before they come on a program, because you want to make someone's ready for it. What you don't want on a program is someone coming in not knowing what their problem is or why they're there, or if there's any unmet needs. So, for example, in our service, we do get people where there are more mental health needs than maybe other services. And sometimes they need to be addressed first before they can come on a program. Maybe they might not be good in groups of people. Maybe they might not be able to do the timescale. So we will always do our best to make sure that the right person ends up in the program and it's at the right time for them. Because they're only going to do it once, generally. Although new PMP guidelines in the country now say you can do it more than once. But we want to make sure it's the right time for them and obviously for everyone else that they're with, so everyone can get the most from it. I will say for our service, we do follow them up at a month, 6 months, a year later. Other services follow them up at different time lengths as well. Sometimes it's a few months, sometimes it's variable. But I would say for our service, at least, a program in the long term is, if you look at all of our outcome measures for everything, the best thing we can offer them.
I think it's fascinating, the whole group kind of community components of that too, that you alluded to, where we have patients who, like you said, haven't really experienced anybody who's walked in their shoes. They've often encountered healthcare people that, if they're trying to validate, hopefully, which unfortunately doesn't always happen, it's hard for them to truly validate because they don't have that, experience to share with somebody that, another fellow person who's struggling with pain does. So I'm wondering what your thoughts are of that whole group versus individual treatment dynamics. They're two different dynamics, obviously. And you said, like you mentioned, like the group dynamic has its strengths and the individual dynamic has its challenges and strengths as well. I'm just curious what you found as far as like the differences and how do you navigate maybe, those challenges between those two different contexts?
I mean, our program, what helps in a way is that it's generally the last thing they will do, just due to the nature of the time lengths waiting in there. Sometimes in our service, as we have consultants, depending on the type of pain they have, they may have had some invasive treatments first. to try and support them with managing the pain. So usually we will see them individually beforehand, and we can get a good grasp of meeting this person at the time. Is this person going to be suitable for groups wise? I would say individually, it is much easier to get to know the person in front of you, because you can ask them things that they might not want to say in front of everyone else. They may tell you things that they, especially if they're meeting a group of people for the first time, day one, they're not going to say certain things in a large group of people that they will feel more comfortable in a private group with you. And you can also get down to the nitty gritty of the, why is this pain going on? What is driving this? What are those, impacts, various factors they've had in life or not, or beliefs, whatever it is, right? Things that are driving their pain. How can we dig down and find those things out? But you're also right in that I can't sit there and say, I know how you feel. I can't say that, nor should I say that. It's not a great way of expressing empathy. And I think actually, yes, individual is better for kind of working out the what is wrong and helping someone with a plan, and kind of the why is this all going on. But I'd say for groups, it's like you have extra support for, I suggest what you're going to do, because usually when we're delivering a group, we'll be talking through various management strategies. So let's say we're talking about, pacing, for example, right? We're talking through the concept of pacing, and they will be talking through it. And you can ask at some point, who has tried this in the past? What have been your experiences? And there will always, provided you've got a decent group of people, someone will say, well, I did this and it led to this and it helped because whatever. And the fact that it's come from them, the person who is like everyone else in that group, they can relate to much easier, and they're more likely to take that in and go, oh, that might be a good idea then. Maybe I can try that. They did it this way. That is much more powerful than me sitting there bringing out a graph and saying, have you thought about pacing before? What do you know? Here's a boom and bust graph, blah, 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 blah. They hear it from someone like them. General psychological research will tell you they're more likely to then do it or give it a go compared to if it comes from us, because they can relate to that person. So I think that part really helps with the implementing the strategies, if you will, the change. There are even programs out in the country now, and we're trying to do this as well, where they will have ex-participants who have done well, ex-participants help in the delivery of the program themselves. And I think that's, some areas are doing it now, just a few, but we're trying to do that. As you can imagine, there's various red tape you have to jump. But that will just add to the making it relatable and just helping them get as much out of it as possible.
The ability to just have somebody who's been there, done that, just the validity in that patient's eyes of their maybe words, even though obviously our words are well-intended and founded in the best science we can found it on. And those things, it's just hard, to equal the authority of status, I guess, of somebody who's, not that we don't have our kind of authority, which I don't even like the word, because we're more of a teammate, a guide by the side, versus this paternalistic authority who's ruling over them. But as far as they look at it, as somebody who's got knowledge that really holds high, regard in their mind, as far as somebody who's been there, done that type of thing. I love the fact that you're doing the teaching and communication. I firmly believe you've probably heard that communication should be looked at as an intervention. We sometimes look at it as this like secondary soft skill type thing, which, as I'm sure you're well aware of in your training and your teaching, it's much more, it's not soft at all. It's very hard. It's challenging, and it varies human to human. Your interactions are always going to be unique. I'd love to hear, before we get into some of the difficult conversations that'll help the folks that are listening out there, I'd love to hear your perspective on communication, of how you looked at it as a physio student, when you're coming through university. I know, for me, that was again, the secondary thing. I didn't even really think about communication. I was just ready to learn how to do the best exercise, the best manipulation, or all those things. How did that kind of transpire for you? How did that kind of progress over from your physio university days to now in practice? How's that kind of transformed, I guess?
So I suspect, like most people listen to this, going through uni, I was taught, I don't know, fairly early on what to say or what to ask. So you're taught fairly on how to, what to ask in your subjective, right? What makes it worse? What makes it better? How is your sleep? Who's at home with you? Tell me your story, all that stuff. And as a student, I was fairly blessed in life that I think whether it's genetics or just experiences I had actually kind of forced me in a way to make sure I could build, have decent conversations with people. And I remember my last placement, my educator, the actual placement itself was a musculoskeletal placement. If you'd have asked me as a student, did I like MSK? I was like, no, not at all. I don't like this. And if you'd have told me what I'd be doing now as a career, I'd be very surprised. But my educator, he had, whether it's the best word to use is charisma or just a presence of, when he spoke to people, people felt listened to and that he was being attentive and cared for. Didn't really make much sense, it's put too much together at the time, but just seeing what he was doing wasn't drastically different to what anyone else was doing, kind of exercise and treatment wise. It was just, but how he was just as a person with them seemed to make the big difference looking back at it now. And then between qualifying and starting work, my father-in-law was talking about a book I'm sure you and many people have read called How to Win Friends and Influence People. And I read that, and that was really the thing that made me go, is that click, that thing. They never taught me this, but now I get why the educator was making the difference. This is the thing that I just felt, now this I can grasp. That's still my favorite book to this day. And you started then incorporating just the basic things. There's nothing particularly technical in it at all. Just basic things of listening, smile, validate, etc. As I was kind of going through the early years of my career, I worked in sports and I worked in martial arts, so I judo and mixed martial arts. One of the things we're trying to implement there was doing things that they can try and reduce the risk of their injuries. And the big dilemma was actually getting them to do it. You could tell them, you could show them what to do. We knew what they could do, but how can we work with them to try and implement these things? And I then started reading more and more various other things around kind of behavior change and this kind of communication stuff, not beyond just what we say, but the non-verbal stuff as well. And then it was really, I'd say a few years into my career when I started getting interested in people with persistent pain as well. I read Louis Gifford's books, which I think many people have, and just all kind of cemented that. And then when I started doing the teaching is really when I realized, there's a lot as physios or physical therapists that, we're taught what to say. We can be patients generally like us, right, compared to other professions. We have an idea of the basics, but the harder things that, what I was then going through in the medical school, the Breaking Bad news, the uncovering things. I wasn't doing it with the death and dying, those hard conversations, managing anger, etc. Those are the things I thought, where is this for us? And I think you're also right. You as a student, you realize that it's important, but you're also worrying about all the treatment things you need to do, making sure you do your assessment right. Our medical students are also, front of their mind is keeping the patient in front of them alive. I think it's only when you qualify and you've been doing it for a certain amount of years that you suddenly go, oh yeah, it's that how I talk to them. That's the thing that makes the difference. Yeah, you learn how to assess, you learn how to treat, you go what to do. But it's how I am with them. And I don't know whether it was for how many years it was, that's what clicked. And I think it's with the schools and the teaching that's made me think, there's this extra stuff that we could benefit from as well.
I think most of us have similarly had that journey where it wasn't emphasized in our practice. In school, as you mentioned, we understood, yeah, it's important. I need to obviously be able to say what I'm doing and why I'm doing it to a patient, but it never really took on the importance of, man, how we communicate, how we are, contextual effects, all those things surrounding interventions that often drive a lot of change more than what we thought. And they're super important. And I know for me that, was resulted in me chasing more interventions and tools in the toolbox, that whole thought process, and falling flat with that. And it wasn't until, reading Gifford's books and having a pain science course and kind of reining in my thoughts of the manual therapy's ability to save the world, that, it was, and patients humbling me over and over and over again when I didn't really take into account how important their story was and be able to co-create that narrative. With that said, you work with a lot of difficult conversations from day to day in a pain clinic. That's just part of the day-to-day operations.
Yep.
One I thought we'd touch upon that you had mentioned as we were kind of leading up in the podcast, which I think folks could benefit from, is these ingrained beliefs. And maybe you choose which one you think is the most common. I think sometimes it's just like, this is this cognitive fusion concept that, acceptance and commitment therapy speaks to, like, where folks are just fused to their thoughts and beliefs on future prospects. And we could probably name them, but I'm curious if you could give maybe an example of some of the ingrained beliefs and maybe how you approach those in practice to kind of open up a conversation to maybe move people in a better direction, I guess.
Well, I guess at the moment, a lot of ones that are trickier that we see. So in the pain clinic, we're seeing a lot these days of widespread pain. The days of us seeing, and I call them the kind of the P2S elevations, but the classic back pain, scared of moving, had the scan, shows you genital changes, fearful, all that stuff. We're seeing less of that now because I think general physical or physiotherapy is getting better at managing with them. But we're seeing a lot of widespread pains. And so a lot of them getting diagnosed with either this fibromyalgia or chronic widespread pain diagnosis. And I think some of the tricky beliefs with that is when someone says, they've been online, they've spoken with someone, and they said, it's not fibro, I think somebody's been missed, or I think it can't be that. Like, this fibro diagnosis says it's all in my head, or I'm making it up. And they're not, if someone's at that point, I think it's probably one of the tricky ones at the moment. And so what do we do about that? How do we work with someone where they've been given the diagnosis by a usually doctor or professional who's done a decent assessment, done the relevant tests, they've had scans, they've had some blood tests, they've had whatever they need to have done. Granted, fibro diagnosis these days, providing you fulfill the criteria and there's no other obvious concerns for anything else, then that's how it's done. But let's say they've had, as most of our patients had, a decent amount of investigations. They say this and they feel, no, it's not that, it can't be that. They're just saying it's in my head. So how do I address that? I'll tell you now, the first thing I don't do is don't turn around the computer and go, well, Jane, you've had this scan, you've had these blood tests. They're all fine, Jane. Facts don't change feelings. We are, as humans, we naturally want to go, let me tell you why you're wrong. Here's some data. Data says this, therefore change your mind, please. Okay? Sadly, as you and I both know, Mark, that's not how humans work. In fact, giving data to people, especially when they've got ingrained hard beliefs, is almost one of the worst things you can do, because it's almost likely to ingrain that belief further. Right? Sometimes people have backfire effect, or it has different names, but you could apply that to this situation. You could apply it to political views, all sorts of things. You tell someone contradictory information to their certain belief that's very far away from where their beliefs are. They'll pick it apart. They'll usually have an answer. An answer something like, oh, I don't trust that because of this. Or I don't believe in that because of whatever it is. So my first question back to them is always, what have you been told? You've been told you got fibromyalgia. Okay. What do you know about it? Or how did they explain it to you? Because whenever having these difficult conversations, whether it's beliefs or other things, I'd always start by finding out what someone knows first and how they feel about it. Because it will, A, potentially save you a lot of time. B, you know kind of what not to do in a way. So I was at a teaching night the other day and they were talking about functional neurological disorder. And the physio who was delivering it said they saw a patient and they were going to start talking about FND. And the patient said, "Oh, please don't tell me about software again." Right. And so, we use the analogy of the hardware and the software for these kind of things. Don't tell me I'm going to be, like a computer again. So always find out what they know and how they feel about it, because that can easily guide you where you're going to go with this. Second thing to say is don't expect to change their beliefs there and then. Right? People don't just change. If the belief is like on the fence and, they've had some where they're not really sure which way to go, then sometimes data and just showing them information, for example, a popular thing to do, physio world, I'm sure we have various colleagues that do it, where they have the degenerative disc disease on the scan, right? And the patient's a bit unsure what it's about, should I move or not? And you bring up that graph which shows, yes, 50% of people your age have these findings, right? And they don't know about it at all. And the patient goes, "Oh, right, okay, well, it's safe to move." Yep, safe to move. Great, move forwards. But for ingrained beliefs, I would not expect it to change in front of you, because often people don't want to lose face, right? It's a bit embarrassing for someone to go, "Oh, actually, you're right." I need to go and think about it. So once I know what they've been told, how they feel about it, then it's a question of you ask them say, for example, they don't believe in it. Okay, so what do you know about fibro? Well, I read this, read that, read this. Okay. I feel I've got this instead. Let's say I feel I've got rheumatoid arthritis. And the person says, and they've seen a rheumatologist, you've spoken with them, they've got no inflammatory features, everything testing is, all the skin scans and stuff are fine. And as I said to you earlier, just showing them the scans and showing them the blood results alone won't just make them go, "Oh, fine, I've got fibro." So you could say to them, "Well, what did you make of that? When the rheumatologist said that your bloods and tests were okay, what did you feel about that? What were your thoughts?" And they may say, "Well, I feel maybe it's something's been missed, or maybe it's this or that or otherwise." And I liked you were talking about ACT there earlier. I'm a big fan of acceptance commitment therapy as well. I think ACT is as someone once described to me, a nicer CBT. CBT is much more, you have this thought, you've now done this, your thought is wrong. While ACT is more, you've got this thought, is it helpful? And ever since I've always had that thought, is it helpful? So if we apply it in this situation, they've shown you these tests, they're having this feeling about the belief and think there might be something else going on. They say they've ruled out everything else. Is that belief helpful? How does that issue? And you'd ask them at some point in your assessment, what are your values, what are your goals? Is this feeling going to help you move towards that? And again, you're not expecting them to suddenly go, "Oh, okay, fine, I'll change, I'll do this, whatever." It's just putting it out there. My boss calls it dropping a seed. Quite like that idea as well. You're just floating it out there for them to reflect and think about. And then what they're going to need is time. They'll be aware, as you've just clarified already, that everything was okay. You can tell them about fibro or whatever the condition is, but only tell them what they want to know. So I always ask, "What do you know? What have you been told?" Da, 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 da. Okay. So they mentioned about this fibro. let's say you've asked them, what do you know? They probably say not a lot. Okay. What would you like to know? Right. I'd like to know about what are the symptoms? How does it happen? Okay. Well, symptoms are this. It happens because of this. And then leave it. Just pause. Don't expect them to go, okay, that's my diagnosis. I agree. Expect them to go, "Ugh." And then if they want more information, give it. But I think the key thing is, if people feel like they're being pushed, like we're pushing them into a diagnosis, we're pushing them in this direction, whatever it is, they're going to push back. Right? They're going to go, no, tough. I feel it's there. So just leave it with them and think, and then you're going to see them again. However long your follow-ups are. So I see them maybe a few weeks, a month later. Okay, we discussed this last time. You asked for this information, which you said you'd go away and read. How did you feel about it? I think if you can avoid pushing, give them time. The key thing with any beliefs or behavior is people need to change. It needs to be their idea. Right? You can facilitate that. In theory, you can guide and edge, but you can't change their mind for them. They need to come up with the idea themselves. I realize I'm being slightly vague with this, but the thing is, as we said earlier, we treat people, not patients. So what will facilitate one person's change in beliefs will be different to another. And I think whatever you can do to work with them individually, with their understanding and their needs, then you're more likely to help them with that. At the end of the day, they may need a medical person in a suit to sit down with them and say, again, look, we've done this, we've done that, it's still this is it. That's fine. Okay. But if you can be, you said a coach earlier, Mark, might be the coach with them, the support, working with them, not against them. I think that's the key thing. Sorry, I just yapped on that for ages.
It was good. It was good. It's interesting, trying to and you can hear it in your discussion there, is like you're trying to create and sculpt a conversation, and it's like you're letting the patient come to these conclusions on their own, but you're creating a conversation that steers that patient to kind of look, their thoughts and what you're kind of having them explore and see if they line up and their beliefs. And I find that immensely challenging, but that's what I find fun in the clinic, is like, how do I dent these beliefs? How do I kind of get through to this person? One, you got to understand, well, where they've been, what do they know, what all the things that you spoke to, and then with every person, as we mentioned already, is so unique and has a unique life experience that brings them to your door. How do you how do you steer a conversation to have them hopefully question things? But like you said, and your it sounds like your supervisor, about planting that seed or throwing that seed out there to just see if you can get enough seeds out there, then hopefully one germinates into something that might move them in a positive direction. I really like that. The other thing that I think communication and difficult communication is when the emotions enter the treatment room, and those often accompany pain, because pain is a very emotionally charged for obviously understandable reasons, when lives are really changed in a significant way, and in not a way that obviously most of us would be happy about, when we're not the person we want to be. And all these things are kind of feel like have been taken away from us, or the biographical suspension type thought processes with it. When somebody comes in like very depressed, we'll say, like where they're just, struggling. And those are often the people when you're trying to kind of go act, well, valued goals, where are they? What are they? What do you want to do? And they're just like, nothing, I don't really have anything. What do you think with depression? I mean, that's just one option, or one thing that might happen when you're asking for goals and they're just kind of blankly not able to really come up with anything, mainly because they just don't see any goals to be had with their current situation. But what is your approach when you deal with somebody who's dealing with that kind of significant depression?
A, have a good box of tissues nearby.
Yeah.
I would say B, we usually like to ask lots of open questions, usually with our patients. So, tell me what's happened with your story. How does this affect you? What are your goals, as you said? But and this is something I picked up when we started doing teaching with about certain psychiatric stuff. When someone is very depressed or even into the suicidal range, actually closed questions are better. They will find them easier to answer compared to open questions. So if someone's been through a very distressing time, whether it's related to their pain or something else has happened in their life, very upset, very distressed, as you say, really quiet, really slow, not looking at you at all, looking at the floor, then actually closed questions are basically the yes or no answer. So, would you like to talk today? Yes. Has the past few weeks been really tough? Yes. We're lucky in our situation. I can see GP notes. So I can see, to give you an example, a few weeks ago, saw a lady, speaking to her on the phone, she says, I've got something to tell you. I said, okay, what is it? My husband left me after 30 years, suddenly. And thankfully, I knew in advance because I could see on the GP notes. But, someone's partner of 30 years is suddenly left, right? Someone else. And, at that point, they're very upset, very quiet. Is now the right time to be making a big pain management plan with various tools and exercises and whatnot? Of course not. You're shaking your head before I even said it. I would say the closed questions. Thankfully, she was a few weeks after, so it was more talkative again. But if someone you're really struggling to get any conversation, actually closed questions work. Take your time, allow pauses. If I would say however long you can tolerate a pause for, try it. Okay, people will fill gaps. We as humans want to fill the gap. If someone sits there for long enough, not say anything, will eventually want to go, want to fill it. So can you, allow them to have that time to fill it? And a phrase that I've heard used in the past few months. Have you ever heard of the phrase sitting in the mud with someone?
I've heard something similar to that.
Past few months, I can't exactly remember where I started hearing it. But essentially, if someone's going through a very distressing time, so we'll take the example of that lady. Her husband's left her after 30 years. She's very upset, very distressed. Life has been flipped upside down. We've already said, not much isn't the right time for me to be going on about all the various pain management tools. And am I going to be able to, and in that half an hour, be able to say or do anything that's drastically going to change how she feels? No, of course not. I can't change that. Nor is the patient expecting me to change that. Most people, if they're going to see their physical therapist or physiotherapist, they know that they're not expecting us to do 3 hours of counseling or 10 sessions of bereavement chats, whatever it is. Okay. They know that we're psychologically informed. Yes, we're taking a biopsychosocial approach, but they're not expecting that from us. They're not expecting to do a whole hour of cat therapy, whatever it is. But sitting in the mud implies listening, which we well know by now is the most important thing you can do. And then just being with them, empathizing, listen to their story, acknowledging what you've heard, and then some form of demonstrating empathy, whether it's something like, it sounds like it's been really difficult, it's like you're going through a lot. Whatever it is, whatever suits the patient at the situation at the time. And you're just being there, take your time, speak calmly, give a little bit of space as well. If you're going through a very distressing time, the last thing you want, I presume the last thing you want, is a therapist, in my case, 6'2", probably be larger than most patients I see, sitting there close to them, looking at them like that, right? Be quite intimidating, not what they want. the time. Give them space, give them time. And if you can't, don't do anything that time. Don't do anything. Just be there. You just being there, listening to them and letting them cry and get it out, maybe more than they've had from anyone else so far. And that's okay. I'm blessed in my pain service. I'm not in a rush, right? We're not expecting any more investigations. We're not expecting any of the things that have a time scale on it. We're with them, not forever, but for as long as is suitable for the input and provided they're making progress. But as you say, it's not the right time to invent all those strategies, but maybe just feeling supported helps build your rapport. So when they come back 2 months later and they've had time to grieve, whatever it is, you get support they need. If you need to direct them to any psychological support or colleagues you have, then do. And when it's the right time, they're then at a place where they can re-engage and they feel also, if something comes up later on, they can open up to you again and tell you something that they may not have told you in the past. And it does happen occasionally. People come out with things, so a few appointments in, that actually they didn't tell you initially, but they then tell you and think, oh, maybe there's a big piece of the puzzle why this is persisting when it hasn't. It's fairly simple things. Listen, empathize, give them space, give them time. I think we maybe as clinicians put pressure on ourselves that I have to make this person feel better. Okay, yeah, pain, but also emotionally feel better. If someone's in the mud, I call it sitting in the mud, not pulling them out of the mud, because someone needs to have that human time to grieve or whatever it is they need to express. So sit there with them and they'll get out when they're ready. You can, you're there with them as they're getting out. I think if we just acknowledge that, be there at the time, and that's maybe all they need, right? They don't need anything more than that. And direct them if needed, and then carry on when they'll follow on with them when it's suitable.
I like what you said with the silences, because I know for me personally, it was very challenging not to want to rush and fill those silences, but just letting silences happen and let people kind of process things and let people, often they'll pick up a discussion. Sometimes maybe after some silence, you can have a gentle cue to, like you said, this looks like it's really hard for you. I can imagine this must be very challenging, and you just kind of let people get it out. And this, I'm also very fortunate where I'm not pressure productivity and things that unfortunately a lot of colleagues that we talk to are, where sometimes the most valuable session can be them just kind of letting that stuff out, feel listened, feel heard, be validated, that you're not just rushing them to get your units. You're a human who cares about what they're going through. And then it may open a door for some discussions, as you mentioned already, where you can start really uncovering some ahas, like, okay, now I'm starting to see how these pieces fit together of what might be driving a lot of the challenges with pain and things that they're having. We got time for probably one more emotion, because this, there's obviously a multitude that arrive in the treatment room from day to day, but a common one that I think people see, and I know we recently just finished up with a student physio in our clinic, and he had a few episodes, which I love being able to see a student, because it's sometimes when you're 20 years in, 10 years in, like yourself, you kind of lose sight of what it felt like and what you were thinking at that time, but to have students and kind of see, okay, yeah, I remember feeling the same way and having those same experiences. But anger was the emotion I'm thinking about, with patients coming in, maybe saying some choice words, really frustrated with, maybe the management or not being heard. I'm just curious, what's your approach when somebody comes in with that type of emotion in the room?
So I was never, but Mark, tell me were you ever coached or just taught in your training anger management skills at all?
No, nothing to do with physiotherapy things. I mean, I remember coaches in sports saying, Mark, you need to tone your temper down. That was about as far as I ever got in anger management, for sure.
Out of interest, when they said that, did you tone your temper down at all?
No, not at all. I mean, that gave me zero skills. It was just like, yeah, you got a temper, do something about it. Well, what do I do about it? I mean, it was just like, point out a problem with zero solutions to the problem.
So I will say anger is a normal human emotion to have. However, when we all think of anger, we're not so much thinking of the emotion, we think of the expression. It's the expression that makes some of us go, like your student, God. Because it's the kicking off, right? People can be silently angry, okay? Just people don't say anything, they just zip it, good old silent treatment in various relationships you might have experienced. But when one that makes us all go, worry is when someone's aggressive, best word to use, or verbally angry. And I will also add that I can only say this from my experience and just observing others. Very rarely, if a patient's angry, especially if you've not met them before, very rarely are they actually angry at you, the clinician. They may be angry about other people they've seen, experiences they've had, the traffic getting in, who knows, okay? But as I asked you there earlier, you said, they said that thing, your temper did change. Worst thing you can say, that probably will cause the opposite. In your experience, Mark, has the phrase calm down ever actually led to anyone calming down at all?
That would be a negative no.
No, exactly. Usually causes the opposite. Calm down. You want me to calm down? And with that, if possible, try to avoid labeling them as angry. You tell someone they're being angry, they're going to be more angry. Okay. So I would aim for different adjectives. Frustrated's a good one to use. This sounds like it's been a difficult situation. But avoid saying you sound angry or you're clearly angry here. Okay. What would I do? Providing they weren't being abusive to me, I would let them go. Let them get it out, right? Let the steam vent and and they will come down over time. And we said about silence earlier and pauses. A pause, they will also in the pause go, and the balloon that's gone up will back out again. And half the time at least, just letting them go, they'll come out of it. I even remember, saw a lady very frustrated at something. Again, not at me. I'd met her for the first time. She was very angry about something. She came back. Next time I saw her, she said, I'm so sorry I was like that. I was like, that's okay. What they've been through often can justify the anger, but how it's expressed may not be justified. I will say to people, yes, patients may be angry, but you do not have to tolerate abuse. If you don't feel safe or it's not being productive, don't keep it going. Don't try to resolve it. If you feel like you're just going around in circles, it's not worth it. Okay, for you and for them. Try to come back to it later if you can, or do whatever you need to do to close it. But certainly, providing you feel safe, providing you feel you're getting somewhere, and actually letting them go, empathizing with them, direct if they need to complain or do anything, then direct them to where they can. And again, although I was saying earlier, most of the time they're not angry at us. I will say to people, if they're angry at something that's happened with a different service in the hospital, GP or somewhere in the NHS, I will say, classic line is, I know this wasn't my fault, but I'm sorry X happened to you. Okay. And an apology, even though they know it's not your fault and you had nothing to do with it, even just a gentle apology and acknowledging that can often help get them on board as well. Moving forwards. I think the key thing I will reiterate though is if you don't feel safe, don't stay there. But from my experience, and it may just be because I'm a 6'2" male, but that is very rare that I don't feel safe at all. But if you do not have to tolerate abuse at all. And if you feel unsafe, just either leave or whatever you need to do to feel safe.
That's great advice. I think, thankfully, I haven't had any times where I've felt in danger myself, but you hear stories. I've definitely heard colleagues talking about things where exactly like you said, it wasn't going to be fruitful. I had to, maybe stop the conversation and kind of move in a different direction. But Ben, we could talk for hours more about this stuff. I've really enjoyed your perspective. You can tell you've had these conversations on a regular basis, and obviously you're teaching people about these conversations on a regular basis, and it shows. So I greatly appreciate your expertise today, and really appreciate your time.
Well, thank you for having me, Mark, and I'll be happy to talk again with anyone else listening whenever.
With that said,
you.
where can folks locate you online if they wanted to kind of pose some questions to you or kind of follow up with some of the things they heard today?
My social media is all the same across Twitter, X as it is now, and Instagram, I think TikTok. It's simply B Whybrow Physio, and you just search that, or if you just search Ben Whybrow into Google, I'm sure my name will come up. There aren't many of me, and that's the easy place to find me. I'm easy to message, and just any questions or queries, that's who I am.
Yeah, and we'll link Ben's social media accounts on our show notes so you can get in touch with Ben. He's definitely somebody who lends some good conversations online, and we're somebody to pick his brain and get his input on things. So again, Ben, thanks for your time today. For those of you who are listening, would love if you could subscribe to the podcast on wherever you're listening, or if you're watching on YouTube, we'd love if you could subscribe there as well. So maybe we can spread some information to some clinicians who are struggling to have these type of conversations in their own practice. But we'll leave it at that this week. We will talk to you all next week.
This has been another episode of the Modern Pain Podcast with Dr. Mark Karjala. Join us next time as we continue our journey to help change the story around pain. For more information on the show, visit modernpaincare.com. Also, visit the Pain Masterminds Network on Facebook for free education and resources. This podcast is for educational and informational purposes only. It is not a substitute for medical advice or treatment. Please consult a licensed professional for your specific medical needs. Changing the story around pain. This is the Modern Pain Podcast.